Good evening, and thank you so much for joining us. We're back with our biweekly webinars. I'm Margaret Crotty. I'm the co-chair of the Board of Advisors, and I'm delighted to welcome you tonight. We have a lot to talk about, so I'm going to turn it over quickly. I also wanted to send a big shout out and thank you to Jeff Kraut, who hosted an amazing meeting for the steering committee of the Board of Advisors yesterday and gave us a master class on COVID, on the vaccines, and on what's happening. So thank you, Jeff. That was really, really useful, and I know appreciated by the group. So as you know, there have been so many new developments with the vaccines, with the state eligibility, that I will turn it over directly to Dr. Bettinelli to introduce Dr. Farber, and we'll see you at the end.
I just want to give you a little bit of good news, and that is that we continue in and throughout the organization to have good numbers. And by that I mean, if you take a look at the top of this this slide, the in-house numbers in terms of the in-house COVID positive patients, you'll see that we've got about 1,200. Similarly, we continue to have nearly 20% of that group in the ICU and about half of that group on ventilators. We certainly have some of the patients who've been in the hospital for quite a while now, so some of the ventilator percent will likely creep up just a little bit. But next slide. The importance of this is so that you can take a look back and you'll see that nearly back into December and until now, we have relatively the same number of patients in the hospital. So we really had gotten up in about mid-January to a scary number. As you can see, about 1,374, 1,380. But as our analytics people in this organization had predicted that in the third week or so of January, we would start to see a decline. So the good news is we're holding steady. We think this number will continue to drop a little bit, but probably as it increased on a slow rise, it will decrease, especially with some of the longer hospital stays for patients. But the upside of this is we've been able to maintain hospital operations, our teaching programs, our research programs, and all our ambulatory and what some refer to as elective surgeries, we refer to a little bit more as planned surgeries, and have had an extraordinary recovery right up until the first quarter of this year. So on that side, it's good news. Now I'm going to turn this over to Dr. Farber to give you an update on all the variables and do our best to predict how this is going to move. And I think a lot of this will be based on how much vaccine and how quickly we can get it distributed. Bruce?
Go to the next slide, please. So yeah, a lot has happened in the last 2 weeks, actually too much to even cover in one session. There's actually enough for 2 sessions. So some of this will kick over to 2 weeks from now, but the vaccines, lots of new questions. Will the current vaccines lose their effectiveness against the new strains? I think that's clearly the first order of business. Secondly, can we ever get to herd immunity if the virus is changing so quickly and we're going to be losing immunity as these strains change? What is the expectation of rates in opening society in the near and long term? Which vaccine is the best? Is it worth waiting for? And what is the effectiveness of the J&J vaccine and Norvax vaccine, which you will see within the next month, more likely than not, being offered to the United States public? Next slide, please. So let's go first to the good news on vaccines. First of all vaccines seem to be very effective in preventing, and I'm underlining the word severe disease, including the very treacherous B117 strain and the B135 strain, which I will spend most of this hour talking about, with very rare exceptions that we will also talk about. Viral, vector, and protein vaccines will be cheap and much easier to produce. They're very easy to store. The single-dose J&J trial was successful. The EUA is scheduled for the 4th week in February, and I'm certain it'll be approved and likely be distributed by the 1st week in March. And most amazing is no serious side effects have really emerged, despite the fact that it's not 25, the actual number should be 35 million people have been vaccinated worldwide with the messenger RNA vaccines. And so for those people who are waiting to see how it goes, the time for waiting is over. Get vaccinated now. If 35 million people have been vaccinated and there's been no real serious consistent problems, that's about as good a number as you will see in any trial of any medication or vaccine. Next slide. So let's talk about these two new ones that you're going to be hearing a lot about in the next 3 weeks. So first, Noravax. It's a great vaccine. This is a pure protein with the spike A protein that we've talked about, and it only contains an adjuvant. An adjuvant is something that's attached to a protein to make it more immunogenic so that the body will respond. Its efficacy has been up to 89% in its trials. It's 2 doses, 3 weeks apart. It's very stable in a refrigerator, a perfect vaccine for pharmacies, for physicians' offices, for areas that don't have a cold chain. It's pretty well tolerated, actually better tolerated in the studies than most of the other vaccines. There were no hospitalizations or severe cases among any participants that were enrolled in the trial, roughly 40,000 people. And new formulations are currently being planned against the new variants, which we will talk about. It's predicted to be available sometime in April in the United States, but that's a moving target. But look for Noravax to ease the burden that is so difficult now. And then, of course, there's Johnson & Johnson, which is the first adenoviral vector vaccine that will be approved in the United States. Overall, its efficacy was about 72% in preventing COVID. That's what I'm referring to when I refer to efficacy. It's an adenovirus that's programmed so it cannot reproduce in humans. There's no concern, again, about getting COVID or a live adenovirus infection from this vaccine. Now, they are using 2 trials. One is a 1-dose trial, and that's the results that have been reported. And the 2-dose trial, which will most likely be even more effective, has not been reported and will require a little bit more time. This vaccine, too, can be stored for 2 years in a regular freezer and is good in a refrigerator up to 3 months. So amazingly easy to use in a pharmacy, in undeveloped countries, in other areas. And their trial was initially going to be done with 90,000 people. It's now 45,000 because the incidence of COVID was so high that they got to statistical significance much sooner than anyone had anticipated. The single-dose trial demonstrated excellent results, but not quite as good as the messenger RNA trials. And we will talk about that now in greater detail. Next slide, please. So what was it with the Johnson & Johnson? Well, the data is limited because the EUA won't be released until February the 26th. That's when we're all going to get to see it. And it was overall 72% efficacious, but 85% efficacious in preventing severe disease, and 72 in the US trial. There were no hospitalizations or deaths in people who received the Johnson & Johnson vaccine in the United States. Now, we got to talk a little bit more about South Africa in a minute. It was only 57% efficacious in South Africa. That's the place where there's this B135 strain that I want to talk more about. This was a 2-dose trial. The 2-dose trial is pending, excuse me. The vaccine was remarkably well tolerated. About 9% got fever, but really it was better tolerated than both of the Pfizer and Moderna vaccines. 41% of the people in the trial had comorbidities. Many were morbidly obese, which was good. And interestingly enough, unlike the other trials, they allowed immunosuppressed patients into the trials, but we haven't seen the details of the efficacy in that group. But it's certainly encouraging that the overall efficacy was 72%, even though there were a bunch of immunosuppressed patients. Now, the definitions of moderate and severe disease were different than in the messenger RNA trials. And that's why you got to read the fine print, because unless everyone's using the same definitions in their trial, it can be difficult to compare one vaccine to another. But what everyone is reporting on is hospitalizations and death. And that was very, very good for the Johnson & Johnson vaccine. Now, I will say the Moderna and the Pfizer vaccine had basically a 100% efficacy against the prevention of death and hospitalization in their trials. So Johnson & Johnson was good, but that it wasn't quite as good in South Africa. And I want to show you in a minute why. Next slide. So a little bit more about the Noravax vaccine. This was 15,000 people. They used 18 to 84. 27% were over 65, a 2-dose trial, 95% efficacy in the original strain. When I say original strain, I mean the COVID that we've been living with for the last 9 to 10 months. 86% efficacy against the UK strain. That's the B117 that's spreading across the world, including the United States as we speak. So there was a drop in efficacy, but not terribly much against the UK strain. A big drop in efficacy against the South African strain. That's the B135, and that applied to the 4,400 participants that were enrolled in South Africa. Now, interestingly enough, in South Africa, 50% of the patients that got COVID in their trial had baseline positive serologies. This is actually a very worrisome and troubling finding, because what it shows is that if you got COVID in the last 9 months, that 50% of the people got COVID again when they were exposed to the B135 trial, which means that prior immunity to COVID from wild type infection was not that good or long lasting when it came to this particular variant. They did not test their vaccine in immunosuppressed patients like Johnson & Johnson did. The protein, again, is the same spike 8 protein, and they combine it with this matrix M, which is the only way you would see toxicity, because the protein really shouldn't be toxic. Next slide, please. So what's the bad news on vaccines? Well, it's pretty clear that updated vaccines and boosters are going to be needed to deal with new strains. I'll talk a little bit more about that. That the current vaccines are less efficacious against both the South American strain and to some extent the Brazilian strain, which for practical purposes, we should lump together with the South African strain. They're very similar strains, but they still prevent severe disease, hospitalizations, and death in the overwhelming majority of people. Long-lasting immunity is going to require boosters regardless of the new strains. And this is the most troubling part. Vaccine distribution is not keeping up with the spread of the B117 and other strains, and we are still a long way away from immunity. You don't have to be a math major to appreciate that our vaccine distribution is not keeping up with the spread of B117, which will be the dominant strain in the United States by March, according to most modeling predictions. And so it's going to take a lot longer to get there before March or April or May. And I think, maybe by the summer, maybe not, but we got a lot of work to do there. Next slide, please. So let's talk about these strains, because that's where all of the action is right now. So first, let's try to get our terminology correct. You see these terms being used in the New York Times every day, and it's important to know exactly what they mean. So the first is mutation, and we all know that a mutation is not a good thing, but a mutation is a single change in the virus's amino acid constituencies, and that is just a single change. A variant is multiple changes that change the original genomic makeup of the virus. And a strain is a variant that exhibits a different phenotype. A phenotype means that it actually behaves differently. So in reality, we should really not be calling the South African strain and the UK strain variants anymore. They have earned the title of strain. We can call the California strain, the California variant, and the Ohio as variant, because we don't know if they're really that different. But a strain means that something is dramatically different. Next slide. So what are the variants or strains, as I said? So there's the B117, that's the UK one. There's the Brazilian one, the B1128. And then there's the South African one, the B1351. And then there's a whole bunch of others, the California, the Ohio, and they're being described all the time. Now, this is what's important. The common mutation of E484, and forget the numbers, in many of these variants is the troublesome part, and that's the mutation that is seen in the B1128 Brazilian strain and the B1351 strain. So let's make this very simple. You have a B117 strain that now has mutations that make it much more contagious, at least 40% more contagious than the original strains. Now, you know that this is circulating around the United States, and as I will show you, it's really a delusion to think that we're going to stop it by screening people coming into this country. The horse is way out of the barn, and that's probably not going to do much of anything at all, and it's already here and spreading. And it's more contagious, and we need to get people vaccinated quicker in order to prevent that from causing our numbers, which are finally stabilizing and going down a little, to peaking up again in March and in April, and pay attention to that. Then we have the Brazilian and the South African strain that are not intrinsically more contagious, but are more resistant to the vaccine. And they contain the E484 variant mutation. Now, it doesn't take a lot of thought to think about how long is it going to take for the B117 strain to develop the mutation of the 484 strain in the South African and Brazilian strain to make a virus that's not only more contagious, but is less likely to be inhibited by the current vaccines. So let's see how that's going to happen and what the data is, and is that a true risk? Next slide. So first of all, before we go on, there's emerging data that says that not only the B117 strain is more contagious, which I don't think is open to discussion, but there's now 3 different papers that have come out and have demonstrated that it's also more fatal and more serious. And those were epidemiologic studies, not laboratory, not case-controlled studies, but there are 3 different epidemiologic studies that all suggest that the B117 strain causes morbidity to be about 1.36% higher, roughly 36% higher fatality rates with the B117 strain compared to the other strains. More to come on that, but it probably is more serious. Next slide. So let's talk a little bit more about these vaccines, and then we'll get back into these mutations and strains. So first of all, there are increased reports of side effects in patients that have previously had COVID with the messenger RNA vaccines. They're not horrible. People just need to take the vaccine and deal with it. I do want to say and bring up this issue of Tylenol and Motrin again, because it has been talked about extensively now in the medical community. And what it has come down to, and it was discussed on my Saturday call with the CDC, is the following: that there have been a bunch of studies in infants, in literally infants, who are given meningococcal vaccines. And the meningococcal vaccine in infants cause very high fever, up to 103 to 105. But it is used extensively in areas where meningococcal disease, which is a highly fatal disease, is common. It's not commonly given to infants in the United States, where we do not have endemic meningococcal disease. And there are a bunch of studies in the pediatric literature that showed that when they gave Tylenol or Motrin to people before the infants, before they got the vaccine, that they were slightly less immunogenic than those babies who did not get it. Now, interestingly enough, when they got Tylenol or Motrin right after the vaccine, literally as soon as they got the fever, there was no change in the outcome. Now, what this has to do with giving messenger RNA vaccines to adults that are an entirely different platform is really not clear at all. And many people say the analogy is silly and it really doesn't matter. But if you want to be totally prudent, what the guidance is don't give the Tylenol, Motrin before you get the vaccine, but take it as soon as you get the vaccine. And I think that's a reasonable and fair argument to make. New trials are now looking at wider spacing between the vaccine. It's now 12 weeks. It seems safe for the AstraZeneca vaccine, which is not about to be licensed in the United States, so I'm not sure of the relevance. The UK continues to mix and match vaccines and delay second doses. The CDC and the FDA continued to think that this is a dangerous experiment. And this is continually debated on Meet the Press and every other show. As you know, one of the consultants to Cuomo, who talks to him twice a week, Mike Osterholm, who we've listened to, feels that this should be done because death rates are going to rise in March and April as the B117 starts spreading across the United States. Others feel that we just don't have enough data and it's better to do this according to the studies. So stay tuned for more on that. Next slide. Okay, so let's go to these new strains again. Most are more contagious. They have a selected advantage. Darwin will tell you that they're going to spread and replace the traditional strains, which is what's happening. It's spreading throughout the United States, and it is inhibited by all the vaccines, as we said, and the monoclonals. But, and this is what I'm referring to, so far 11 isolates have been reported that are B117 strains that have the E484 strain in them. Now, to date, all 11 of those isolates have been identified in the UK. So that's good news. The B117 strains that are spreading across the United States so far do not have the E484 mutation in them. And that's very good news. What's going to happen in the future? We have to say. A skeptic in the audience would say, yeah, but the United States isn't looking at its strains nearly as closely as the UK, and that's certainly true. The South African and the Brazilian strains and those 11 strains from the UK all have moderate resistance to the current vaccines, but will again prevent severe disease in roughly 85% of the cases. Unfortunately, all of these strains, the South African and Brazilian strains, are going to be much less inhibited by the monoclonals, which we are now using extensively for early COVID in people and as a prevention in new studies. Next slide. So what about this 484 that makes life so treacherous and is a dangerous cloud on the horizon? So you can see that if you take people who have been infected and you use their antibodies, that it is present in the South African and Brazilian strains and leads to a tenfold is a lot, inhibition of neutralization by human strains, which means that this is a problematic mutation in terms of antibodies preventing disease. Now, the N501, which is the part of the UK strain, is totally separate, and that's the part that increases the transmissibility. And so these are the two things that you have to watch week by week. And the Times has done a very good job as distinguishing these two and reporting on how they are spreading. Next slide, please. So just to go into a little bit more detail on this South African strain, which is the only real worrisome one. It's evolving. It's being reported in other parts. It's not certainly limited to South Africa and Brazil. It has 9 mutations in the spike protein. That's a lot. It's of concern because the accumulation of mutations within the region of the spike proteins is highly suggestive of escape from neutralization by either vaccines or monoclonals. And that's what needs to be watched for. And that's why the new vaccines are going to be needed down the line. Next slide. This is what it looks like. It is this E484. It's a single part of the spike A protein, and it causes the escape from these neutralizing antibodies. Next slide, please. So what are the implications? The majority of monoclonals, that's the Regeneron and the Eli Lilly, which again are both being used. We are doing a lot of them. We've done over 1,000 to date and are well on their way to licensure, and they will not be effective against these South African strains. Now, in fairness, Lilly and Regeneron are quickly changing their monoclonal antibodies, and they will have a new one out. I can't tell you when it's going to come out. And we're going to need to just keep ahead of these mutants and newer strains. And that's what I think life is going to be like for the next, for the foreseeable future, quite frankly. Now, and again, not to be too depressing, because there's also T cells, as we talked about, and interferon and other mechanisms to escape from this virus, and they will not be changed by these genes. They're not going to inhibit T cell response. So that's why I think in part, there's still going to be good protection against severe disease. Next slide, please. So the conclusions are that most individuals infected with previous COVID-2 linkages will not have immunity or neutralization ability against the South African strain. So it's pretty clear that you're going to be able to get this strain again. All the more reason to get vaccinated. Not that it may prevent this strain entirely, but it will keep you out of the hospital and prevent you from dying. Next slide. Regarding immunity, it appears that real COVID immunity with a traditional strain, forgetting these new strains, lasts for at least 3 to 6 months. That's the good news. The presence of serum antibodies indicates that the infection with COVID-19 is very unlikely for 6 months. And receiving the messenger RNA vaccine confers good immunity, but its length and is not clear, and it is not quite as good, as we said, against these selected strains. We still don't know how common asymptomatic infection is after vaccination, but there was terrific news this past week based on a study with the AstraZeneca vaccine that I want to show you. And this is really good news. Next slide. So I'm going to get to it in a second, excuse me. First, let me talk to you a little bit more about these spike A proteins. So another piece of good news that got buried in the news with all the vaccine data is that LabCorp and Northwell will have up and running antibodies to the spike A protein within the next month. This is really good news for a number of reasons. To date, anybody who's had antibodies done by any commercial lab has had antibodies done to the nucleocapsid protein. That is not the spike A protein of the coronavirus that we're talking about. So it's a surrogate, and it's a marker that showed if you have been infected by natural immunity, but it's not the marker that you're particularly interested in. You're interested in the marker to the spike A protein. And it's one of the reasons I've told people who got the vaccine or getting the vaccine, please don't get your doctor to measure antibodies, because they're not going to be there, because the antibodies are to the spike A protein, and it's just going to upset you, and you're going to ask me for another booster, and I'm going to tell you it's not necessary. Now, neutralizing antibodies, which are the antibodies that are done in all of these vaccine trials and are very good predictors, are not commercially available. And that's where they're taking real virus and seeing how well your antibodies in your serum neutralize that virus. So those are just not practical, other than when they're being done in a research lab. But antibodies to the spike protein are practical and are coming. And let me show you how good they are. Next slide. So this was a study that was done by Oxford University and Cambridge, and it looked at 12,000 healthcare workers who participated in 31-week trial, and they were all measured for anti-spike antibodies. Next slide. And what they demonstrated was pretty impressive. What they demonstrated is that almost 11,364 healthcare workers had negative spike antibodies at the beginning of the trial, and 223 had positives. And during the trial, what they noticed is that those who had positive spike proteins had only 2 or 3 individuals developed COVID, whereas the group that were negative had a very large number of COVID people developed. So the presence of anti-spike proteins had a dramatic change. 223 to 2 is the difference in those who had spike protein antibodies compared to those that did not, which is really pretty good. Next slide. And these were the 3 people that broke through who had it, and none of them got terribly sick. Most of them were asymptomatic, which again demonstrates the importance of having antibodies to spike a protein as being protective. Next slide. So conclusion was that in this trial, anti-spike antibodies were associated with a substantially reduced risk of developing PCR-confirmed COVID over a 30-week period of time, and it demonstrates that previous infection or infection from the vaccine are highly protective for at least 6 months. Next slide, please. So how long do these COVID antibodies last? Well, that's not as good as we'd like. It looks like in 95% of people, when they had antibodies from natural infection, they declined over a period of 6 months. And at 2 months, 28% no longer had antibodies measurable. That doesn't mean that they don't have immunity, but you can't measure it and it's declining. Some of these people, 1 in 5, had antibody levels that were so low that it fell below the threshold for seropositivity in the second case. So we need to learn more, but again, it's a wake-up call that getting these vaccines probably is not going to be lifelong immunity. Next slide. And let me move on to a couple of other topics before we open this up to question. The first I want to clarify is the terrible conflicting advice that pregnant women were given these past 2 weeks. So we previously said, Northwell has said in multiple communications to its obstetrical patients and its infertility patients that we stand by the CDC's guidance, which is that the advisory committee and the CDC have been applauded for coming out with statements encouraging and not discouraging pregnant women who are pregnant and getting the vaccine or people trying to get pregnant by stating there's no biological plausibility that this vaccine hurts the unborn fetus or interferes with fertility. Now, the WHO came out and scared a lot of women by saying that it recommended that pregnant women not receive the vaccine unless they were at particularly high risk of exposure due to work or other conditions. Now, first of all, every pregnant woman living in the world is at high risk of getting COVID now because COVID is endemic all over the world. And secondly, the reason that the WHO did that, and they subsequently retracted the statement, by the way, is because the WHO has, quite frankly, a different agenda than the CDC does. And not that I believe that everything that the CDC has been so wonderful over the past several years, but nevertheless, their agenda is basically the United States. And the WHO's agenda is the world. And quite frankly, we are not the world. And although it's great to think that all people in the world should have equal access to vaccines, which is their stance and which we all agree with, at the present time, that's just not practical. And so to say that unless everyone in the world has access to the same vaccine and all pregnant women across the world have access to the same vaccine is just not practical right now in the United States and in Europe and these other countries. And of course, we want all these other countries to get it, but it's just not going to happen in the next 2 months. And so I do think we need to do what's real. Next slide. And so as a result of this, ACOG, which is the American College of Obstetrics and Gynecology, and the Society of Fetal and Maternal Medicine quickly came out with emergency statements to refute the WHO. The CDC reported on Saturday's call that currently they have a registrar of over 15,000 pregnant women who have already been vaccinated with no reports of a problem. And they're also recommending that in the right setting, that the monoclonal antibodies can also be used in pregnancy. Regarding fertility, it's trying to prove the negative. I can't prove to you that Diet Coke doesn't interfere with fertility, but every reasonable infertility specialist who has thought about this says that it's not biologically plausible, meaning there's no mechanism, to suggest that these vaccines will interfere with fertility or, for that matter, with the developing fetus. And biological plausibility is necessary before you devise any medical experiment or trial or anything else. You can say this vaccine could cause me to grow a second head, but it's just not biologically plausible. And so that's why I think ACOG and these other obstetrical groups have taken such a firm stand on this, because there's no doubt that COVID causes major problems in pregnant women, and that's why. Next slide. So I want to just quickly go through a few more slides. It's just taken longer than I thought, but this is the great news. This is the AstraZeneca updated trial. It's not from the United States, but what they demonstrated was that 2 standard doses of the AstraZeneca vaccine produced efficacy of 82% during a 3-month interval between the vaccines. It's pretty good, and no serious severe diseases. But this is the part that was so impressive. Unlike any other trial, the AstraZeneca trial actually did PCR swabs in the UK population on a regular basis. And what they demonstrated was that it dramatically decreased the number in people who were asymptomatic as well as symptomatic. And so now we have the first evidence that we don't have to be overly worried that even though we got vaccinated, we're going to be spreading this virus to other people with any degree of frequency. Next slide. So here's the results. So I don't want you to spend too much time, but let's look at the bottom line. This looks at symptomatic, okay, the red circle, cases after a single dose of the AstraZeneca vaccine. And you can see that after a single dose, the efficacy was 76%. And that was in symptomatic people getting COVID after the first dose, after 21 days after the first dose. Now look at the bottom. These are asymptomatic infections after 20 days that were picked up only by people who were coming in and getting screened by a swab, even though they felt great. And the efficacy there was 67%, with very few people getting asymptomatic disease, only 13 in the entire group. So it's not 100%, but this is considered very good news that asymptomatic infection with COVID after vaccines that cause it to spread around is going to be uncommon. Next slide. Okay, so let's finish up by talking about, the restrictions on travel. There's now data out that I think support that this is more a political statement than a medical statement. As you know, you can't come in from the Europe or Britain without proof that you're negative, and that certainly seems reasonable, I guess. Not that many people are traveling, and that's fine. But in reality, I don't think we can think that this is doing a whole lot. Next slide. So there's data from this, and I just want to show you the data that's been published. It demonstrated that one study early in the pandemic in closing down Wuhan, China, prevented nearly 80% of COVID patients spreading it to other countries outside in China in the first several weeks after it was imposed. But we're living in a different world than we are last December and January. And every study that's been done recently shows that it has a minimal effect. And by September, these studies demonstrated that international travel has not really decreased, international spread, has not decreased significantly now that the virus is so ubiquitous. Next slide. Coming soon, Denmark will be the first one, but I assume this will happen in the United States. It's part of Biden's plan, and that you will have an electronic passport. There's no doubt in my mind that either positive serology or a vaccine at some point in the future, not until it's approved, will be required to do a lot of things in our country. Next slide. I will end on the ongoing problem that has not been solved, and that's vaccine hesitancy. As I indicated, now is the time to get it. I am not happy that healthcare workers and other people are still turning down the vaccine, even though it's being offered to them at a rate that's too high for us to be happy with. And we can't force them at the present time, but at some point in time, I think arms are going to need to be twisted a little bit harder. Next slide. People are starting to do this. It's hard to do. Workers in healthcare in Kentucky who refuse the vaccine are no longer going to be given paid medical leave if they get sick. They're not going to be given disability if they get sick. Other places are paying people extra time if they take the vaccine, but are not giving them time off if they don't get the vaccine and remain sick. And a bunch of people have been resigning from some employees who have twisted their arm, even though they can't legally bind them to get the vaccine. So stay tuned. This is going to be a big topic over the next year, certainly not over the next month or two. Next slide. And I want to just thank two people who helped me a lot with slides. There's Amelia, who's a pre-medical student who's working per diem in our section, and Tony, who just finished college and is also working per diem. And I really appreciate all the work they do because they help me out a lot. Thank you, and I'll stop there.
Great. So Dr. Farber, you've answered a lot of the questions that have come up, but there are still a few more. One is the question of, if someone has recovered from COVID, do they still need both vaccination shots? I guess there was an article that indicated they may only need one of the 2-dose vaccines.
Yeah, that's the article that came out from Mount Sinai and has been discussed extensively. And I know that the people at Sinai published that it was based on a very small population. And certainly all traditional groups say that it is way too premature to do that. And you really should have longer follow-up. So we encourage all of our patients to not read one article in the newspaper and decide they don't need the second shot. I would take it. Your arm is going to hurt. There's no question. You may get fever, but take the shot. It's clear that, antibodies are lost pretty quickly after natural infection. And it's also clear that this vaccine produces much better and more potent antibodies than natural infection. So yeah, I certainly don't think that we should be doing that.
And then in some cases, people have been diagnosed with COVID after receiving their first shot. How long should they wait until receiving the second shot? Do they need to wait an additional amount of time?
Yeah, so this comes up all the time because COVID's very prevalent in the community, and one shot does not prevent you from getting COVID. So it's actually very common. And the answer is as follows, that you need to wait at least 10 days to get your second shot after you've gotten COVID. So, if you get COVID in the first 3 days after your shot, you can get the second dose on time. If you get it 3 weeks into the injection and it's the Moderna vaccine, you need to wait at least 10 days. Now, the exceptions to that rule are if you get monoclonal antibody because you're elderly or sick and you just got your vaccine and you decide I'm not going to take a chance and I meet the criteria for getting monoclonal antibody and you get it, then you have to wait 90 days to get that second shot. So that's the exception to the rule. I try not to give monoclonal antibodies to people who are pretty far out from their first vaccine if they get it. But if it occurred right, within days and they have underlying comorbidities, then giving monoclonal antibody is a reasonable thing to do when you delay the vaccine 90 days.
And then there's a question about vaccine side effects. Someone got their second vaccine and didn't have any side effects, and they were worried if there's a correlation between the severity of the side effects and the efficacy of their vaccine.
Yeah, many people talk about that, and the answer is really not clear. It hasn't been studied. I mean, there is a difference between immunity and reactogenicity. And reactogenicity is the medical word to describe my arm hurts, I have fever, chills, sweats. And, certainly that has been studied a little bit more in pediatrics because most people don't have a lot of reactogenicity in adults when they get shots. A little bit, but not very impressive. And certainly nothing like has happened with the COVID vaccine. So the answer is, I really don't know. I don't think that it's a major worry. And even in pediatrics, the correlation between reactogenicity and immunology or immunity is not very good. So I wouldn't lose sleep over that.
And then for people who've had 2 COVID shots, both shots, and they've been exposed, do they still need to take a COVID test to see if they have COVID?
Oh God, what a good question. And so I can answer that question in several different ways. And this also came up and was discussed extensively on the CDC call on Saturday. And the way it's coming down, like a lot of things, is some politics and some reality. So 2 weeks ago, the CDC announced, and this is very important to the healthcare system because we have people exposed all the time. And they say to me, when is it that our healthcare workers who have properly gotten vaccinated are not going to have to quarantine if they've been exposed to a case of COVID, which happens frequently in their workplace? And the CDC said they were about to change the guidance and basically answer that question and say no, that statistically speaking, you're not going to get COVID at a 95% level. And if you get it, there's a very good chance that it would be asymptomatic. And there's an even better chance that you wouldn't spread it, and it's time to work on the vaccine. Then they got nervous, quite frankly, because of the variants that are spreading. And so they've asked to see a little bit more data and to delay that guidance. And then in the call, it came out, but a lot of states are already doing this. And the CDC said, yeah, we understand that. And we're not opposed to states doing this, but that's up to the individual states. And after all, the CDC only makes guidance and the states make law. And in New York, the law hasn't changed. And, a lot of laws haven't changed in New York, and a lot of guidances haven't changed that have changed in other areas. And that's just the way it is. So if you're asking me as an employee of Northwell, I cannot state on this webinar that we can do that at the present time, although I would like to. If you're asking me for a private person on this call, that if they've gotten 2 vaccine doses and they're asymptomatic and they feel fine, I don't think it's terribly important that they get tested.
Then another question that's come in, can our immune system withstand the onslaught of continuous vaccines if we're getting vaccinated and then we need more COVID boosters? And is it possible that will open us up to other infections?
No, I don't think there's any evidence that getting vaccinated with multiple boosters will produce a problem. I mean, let's look at the examples. We're used to getting flu vaccine every year. And quite frankly, I think, as people know, I think anybody realistic realizes that COVID's not going to go away. I mean, ever. COVID is with us to stay. We're going to have to deal with it, and we will deal with it, and we will. But so multiple vaccines will be required, and multiple vaccines are given all the time. I mean, every pregnant woman now gets a DTaP on her 3rd trimester. Even if she has 5 babies in 5 years, she's getting 5 DTaPs. And there's no evidence to say that giving boosters is going to cause a problem. It's done all the time, and no, I don't think that's a problem.
And then we've also gotten some questions about the new announcement this week about people who are immunocompromised. Some specifics have come in regarding different conditions, but wanting to check in with you on what the current status is in New York State around that round of vaccination.
Right. So, as you know, everyone should be confused, as we all are, because the guidance has come out that next week, that they will open it up to another enormous group of people, which are people under the age of 65 who have comorbidities, hypertension, a BMI over 35, immunosuppressed people. And, the state has come out with guidance saying that you as an individual will just have to attest online under oath that you have one of those conditions, which they will outline for you. Quite frankly, although we've come up with a definition of what immunosuppressed is that I'm happy to share with people, I won't read it off for you on this webinar. The state has not come up with a standard definition of what immunocompromised is. And your definition and my definition could be different. People say to me, I'm a cancer survivor. I had a basal cell carcinoma removed from my forehead 5 years ago. And we kind of chuckle, that's not, I think, what the intent was. But nevertheless, in reality, people are going to have to attest to this. And I think it's just, as I've said all along, ultimately it will be the honor system. Whether people are going to try to get notes from doctors, we're wrestling with that. I don't think it's going to be practical. And I think it's going to be up to the individual to attest. So in answer to your question, stay tuned, but I don't think it's going to be much of a vetting process.
And my understanding is right now it's only New York State who's authorized to give those vaccinations.
Oh, what do you mean? Only New York? New York State has to give you a license. Individual people can apply to New York State. They're being distributed, as you know, by either the state, the county, or our health systems. But people are allowed to apply. In the past, people have not, quite frankly, because it's such a headache. It's such a loser. And so that's why the responsibilities have fallen to the health system like our own. That'll change with the J&J vaccine, and certainly the drugstores will start getting it in greater frequency. And, drug chains can apply and get licenses. And I'm sure that will be a helpful thing with the Norvax and the Johnson & Johnson and even some Moderna as the supply increases.
And then the last question, which I'm optimistic about, but not very optimistic about, is just wondering if you have an expected timeline if you think it'll be about 2 years before we can relax the masks and the social distancing, or with the new vaccines in development, if you were to put a timeline out there, what it might be.
Well, it's a hard question to answer. And, from my own personal, and this is personal point of view, and I actually hope to God that I'm wrong about this, but I do think that we'll be dealing with COVID for a very long time. It'll be dramatically better. We will be getting vaccines, and we will stop wearing masks to a large extent, just the way we do in a terrible flu season. Because after all, we've had really bad flu cases and people haven't worn masks. Maybe they should. We have no flu this year with masks, but there will be certain events that, will be so crowded and so problematic that people will wear masks for a long time. I mean, I could see people wearing masks in a crowded subway from now going forward. I don't know why they'd take them off, so time will tell.
Well, thank you, Dr. Farber. I think we probably had more questions that we could go on, but we're way over time. And I really do want to thank you for this. It's such a gift that you give to us and the whole community every 2 weeks. Thank you. And we will see everybody in 2 weeks. Our next webinar is February 23rd at 6 p.m. And until then, stay safe and be well. And thanks again for coming tonight.